Dr. Stephen Hwang is going to lead this, and we look forward to it. We're all going to learn a lot tonight.
Yeah, this is so cool. I want to thank SpineArt for their industrial support. Without the generosity of our industrial sponsors, this free, high-quality education would not be possible. And our colleagues with Dr. Hwang and his partners are going to take us to the world of pediatrics. And we as adult spine surgeons owe so much, if not most, in our instrumentation from our pediatric colleagues. And the learning should continue. So thank you for taking the time to indulge us with your knowledge. And we're really looking forward to learning from you. Dr. Hwang, do you want to introduce us to your group and the topics tonight?
Certainly. Thank you very much for having us, Dr. Tavin, Dr. Geyer. I have my four colleagues, Dr. Samdani, Dr. Ishmael, Dr. Pays. I'm from the Philadelphia Shrine. We're basically going to present some four interesting cases. Please type in any questions you have as you go through them, and I'll try to moderate and get these questions out and answers. And then hopefully these four different cases highlight kind of different complexities and management issues with scoliosis. So I think first we have Dr. Ishmael who can talk about a complex neuromuscular scoliosis. Dr. Ishmael, if you're ready to jump into it.
Yep.
Thank you.
Hi, good evening, everybody. I'm Terry Ishmael from the Philly Shrine. Tonight, I'm going to talk a little bit about neuromuscular scoliosis. Neuromuscular scoliosis is a very broad term, can encompass a large number of conditions. The most common condition that we actually see is cerebral palsy, but we also see patients with spinal muscular atrophy, myelodysplasia, such as spina bifida, spinocerebellar dysfunction, and also myopathic conditions such as Duchenne and Becker's muscular dystrophy, arthrogryposis, and congenital myopathies. As I mentioned earlier, CP is the most common diagnosis that we see with the more severely involved spastic quadriplegic patients, encompassing the vast number of patients that we take care of. The surgical indications of these patients are typically individualized. Ideally, we want to get to curves before they reach 80 degrees. There have been some studies from the HARMS study group and others which have actually shown that outcomes are superior with curves under 80 degrees. And, the aims of surgery, are to prevent progression, prevent pulmonary deterioration, and alleviate pain caused by the deformity, and also restore alignment, improve hygiene, and improve sitting tolerance. SMA is a genetic anomaly that is based on a gene mutation of the survival motor neuron gene. All patients lack SMN1 protein, but the severity of disease is based on the number of functional copies of SMN2. There are three types, with one being the most severe, with children often dying before they reach 2 years of age, with type 2 and 3 being less severe. Over the last 10 to 15 years, there's been a paradigm shift in the treatment of these patients with the development of new medications. These have greatly changed the outcomes. My case is a patient who presented to me a few months ago. He was a 14-year-old male with a history of SMA type 2 with a severe kyphoscoliosis. He'd been on one of the newer medications for the last few years. He has severe restrictive lung disease. He's actually on BiPAP at night. He's non-ambulatory with multiple upper and lower extremity contractures. These are the images he presented with. On the left, we have a PA film, and you can actually kind of see axial of this spine at the cervical thoracic junction as well as the thoracolumbar junction. When you look at his lateral, he has almost 180 degrees of kyphosis and 90 degrees of rotation. Fortunately, with traction, his spine, uncurled a little bit, but at this point, it's a little difficult to try to figure out what to do for him.
Terry, can I ask you, so when you see this kid come into your clinic, what do you worry about aside from this horrible curve? So are there features in the history and the patient that kind of elevate your concern, or basically you can help you anticipate more complications of how to manage it?
Yeah, I think my biggest concern when seeing a patient like this is his pulmonary status. He's already come in and he's on BiPAP. We had some PFTs on him which showed that his FEV1 and FVC were about 30% of predicted. He's on BiPAP at night. And, I think that, one of the biggest worries with these patients are dealing with their pulmonary situation postoperatively. is not unheard of for our more severely involved patients to remain intubated in the ICU for several days afterwards. And also, this kid in particular was quite small and cachectic looking. So, ideally, you want to get some weight on him before surgery and ensure that his nutritional status has been optimized.
Great, thank you.
Yeah. So we decided to place him in halo gravity traction. We applied the halo and we gradually applied weight over the coming 6 weeks. We got up to about 50% of his body weight. You can kind of see the progression from left to right. They kind of plateaued around the second to third week of traction, which is something that we commonly see. You can see this nasal gastric tube that's part of our protocol for treating these patients. He actually put on about 4 kilograms, which brought him up to around 30 kgs, which is still pretty small, but it's kind of a big plus in getting these patients into the hospital and halo gravity traction. Now, after about 6 weeks, we took him to the OR. We did a posterior spinal fusion instrumentation from T2 to the pelvis. We utilized intraoperative traction and did posterior column osteotomies from T7 to T11. It took about 8 hours. Steve actually helped me with this, and we lost about 1 liter, which is about 1/2 of his blood volume, which for this type of procedure is actually quite good. And he did so well that he was extubated at the end of the case. And, he spent about 5 days in the ICU and went to the floor, and he was actually discharged post-op day 7 or 8. And I actually saw him a couple of weeks ago. These are his final films before he traveled back home. And you can see that we obtained a really good correction. Preoperatively, he had about, more than 45 degrees of pelvic obliquity, flattened the pelvis, and it improved his sitting position. I was a little worried about his cervical spine and the risk for PJK and put him in a soft collar, but he's actually done really well. And we're just going to keep him in that for about 6 weeks.
So Terry, can I ask, what do you do after to avoid trying to minimize PJK in these kids? Like our literature supports maybe 30% of these kids seem to develop it radiographically.
Yeah.
What do you like to do to try to prevent that from happening?
I think that, trying some sort of, stabilization afterwards with some sort of collar, I think is a good idea, particularly in the kids who've been in traction for a prolonged period of time. There may be a little deconditioning of the kind of postural muscles of the cervical spine. Also want to make sure you don't end at a short transition point at the cervical thoracic junction. I had toyed with the idea of going a little bit higher with with my instrumentation, but decided to stop it at T2, and it's worked out pretty well. I know at our institution, occasionally we will do an ACDF to help with anterior support in select patients, but for this kid, we didn't think that it was necessary.
So, Josh, I'd love to ask you, obviously, this is an extreme severe case. What are your general indications when to treat neuromuscular scoliosis?
For us, it's when it starts creeping up to in the 70s, when we can take care of it, it's usually best to do so before it really gets out of hand. I think that's shown to decrease complications and improve efficiency in the operating room. But obviously, there's some that just are neglected, and you have to take care of it. But typically, when it's pushing 70 into the 80-degree range, when you want to take care of it first, that's been shown we've been able to take care of it most likely in 1 day, because staging these kids can be a lot on them, and that's what can increase complication rates.
Thanks, Josh.
This is Jens Chapman. Dr. Hwang, let me ask a question. This is an amazing case. And again, you have my fullest respect for taking this on and doing this so beautifully. 2 questions, weight and hips. So do you use a peg tube, especially in the neuromuscular patients, to kind of fatten them up, beef them up? Because that was always one of my big horrors. And then hip flexion contractures, how does that weigh into your decision-making? Does that loosen up with the halopelvic traction, or how do you handle the potential influence of having the pelvis so offset? Thank you.
So for typically, if the patient comes with a peg tube, or if we've anticipated that their oral intake in the 6 months leading up to surgery, we may consider putting in a peg tube or having them seen by one of the pediatric surgeon. We do have a multidisciplinary cerebral palsy clinic, and that we have all these patients seen by one of the orthopedic surgeons, rehab doctors, PT, OT, and speech. And speech is particularly important in ensuring that these kids can actually, take in the appropriate amount of nutrition. If they're unable to, then oftentimes we will get a PEG tube. I also do this with I do hip surgery as well. We also do this for the hip reconstruction patients. So it is not uncommon to pull it in, but it's not something we do routinely. Again, the vast majority of these patients do get a nasogastric tube for alimentation, and this has really been shown, in our series to kind of help with them putting on weight in the hospital, and that's pretty much our standard of care at our institution. And then with regards to the hips, he didn't have very severe flexion contractures. Both of his hips are actually dislocated. His range of motion is pretty decent. If these kids do have flexion contractures, I will put a sling on the table so that we can actually allow the hips to flex. Because, if we, attempt to extend them, we can, hyperlordose the lumbar spine, and that would be less than ideal. So for him, I did not use a sling. I put about 10 pounds off of the halo on the top and then use skin traction distally. Skin traction is an option. Sometimes we'll use a traction bow apparatus with a traction pin through the femur, but I've kind of moved towards using skin traction through my experience in training.
Thank you, Terry. And Amr, obviously this kid doesn't have any normal parameters to start. If you look at radiographically, these are clearly very abnormal x-rays. What would be your typical goals of surgery in terms of, do you have a target radiographic correction?
Yeah, Steve, that's a really good question. And I guess the first thing that I think about when I think about severe neuromuscular scoliosis is complication avoidance and doing everything to minimize those, whether that's TXA, whether that's nutrition, much like, Hens had brought up a little bit earlier. That's first and foremost, because as numerous authors, including our team, has shown, up to 40% will have some sort of major perioperative complication, really high number. So that's really the first thing. And that may mean that you have to put in fewer screws. You may not want to stage the kid. I mean, these kids get treated differently. So that's the big picture part of it, optimizing preoperatively. Then, of course, there's the surgical goals. And as we know, we're trying to leave a balanced spine, trying to get the hips leveled out, which Terry and you guys did beautifully here, the shoulders as level as we can get them. And then trying to decide, so the coronal plane, axial plane, I think is easy. You're trying to get, leave a balanced spine. In the sagittal plane, it's really challenging. There's really no good parameters. All of our sagittal plane parameters come from walking healthy adults. And what you really want to do is to make sure that you don't overcorrect the sagittal plane. You want to make sure you understand what a neuromuscular child's ability to use their hands are. Some of the mistakes I've made in the past, not relevant here, is if you straighten a kid out too much that's used to kyphosis, they may not be able to self-care for themselves or feed for themselves. So I would say overall goals, avoid complications, don't overcorrect the sagittal plane. This is a beautiful result, Terry.
Great. Thank you, Amr. And just to finish off this question, have each of our panels maybe give one piece of advice about complication avoidance in this population. Obviously, it's a very high risk. We all see these complications, but what's one thing you like to do to help minimize post-op complications?
I go for nutritional optimization beforehand for me. That's one thing. I think you can elevate their protein stores or pre-albumin, those kind of things, fatten them up a little bit, just like Terry talked about. I think that gives you a good head start.
Terry?
Yeah, for a case like this, I will often ask a partner to join me. I think that's invaluable in terms of getting the patient off the table as quickly as possible. Yeah, I mean, our fellows are great and they're all fairly accomplished, but I think that, getting this case done with, typically we do this with either Josh or Steve, and, it has definitely helped getting patients on and off the table as quickly as possible. I think that if I'd done this with a fellow, that might have been 2-3 hours. Maybe, I could have gotten closer to, one blood volume loss, and then, patient might have remained intubated for a day or two afterwards. So that's kind of my preference for a case like this.
You're saying you don't regret asking me to scrub with you?
It depends on how much I hear about it afterwards. But
and Amr, would you have anything? Any words of
Yeah,
wisdom?
yeah. So I think those two are just excellent points, making sure you've got the right help across the table from you. Then, along with nutrition, I think just minimizing blood loss, making sure TXA, we've known about this since 2010, but making sure it's dosed appropriately. We would underdose TXA. Regularly, we'd have a 10 loading milligrams per kg loading and 1 milligram per kilogram maintenance. You got to dose it the right way, 30 mg per kg loading and then 10 mg per kg as a maintenance.
Great. Thank you, everyone. Let's move on to our next, and this is questions. Again, feel free to type in any questions into the chat. We'll try to discuss those and address those. We have Dr. Pei speaking next on a slightly different, but equally complex child.
All right, you guys see my screen okay?
Yes.
Great. All right, so we'll talk about halo gravity. We've already touched on it a little bit, so I'm going to gloss over part of the beginning of this because it does already address some of the things we've chatted about. This just talks about some of the background for halo gravity traction. Initially started out with halo pelvic, halo femoral. But obviously, these kids weren't allowed to move around, so we've moved now and gravitated towards halo gravity traction. Sponsler probably did the best paper recently. It's been a little bit, but what they looked at didn't really necessarily decrease the curve corrections or time or EBL, but has dramatically reduced the number of vertebral column resections, 3 column resections we have to do, which I think is important in these patients who have severe deformities. If we don't have to do that, that definitely decreases our neurologic risk. This is a typical patient we'll see. This is an AIS patient who came in with neglected scoliosis with a rather large curve. And we were able to put them into traction for about 5 weeks, give us a little bit of a head start. And this is obviously something that's easier to take care of than what we started with. And we're able to do a fairly large curve without any VCRs, but we did our posterior-based discectomies because she has about 90 degrees of rotation of the apical vertebrae, so it's easy to cut the rib there, reach around and do a discectomy from the back, almost like an anterior release from the posterior approach. And then we're able to do this all from behind in one single stage without a 3 column resection. How long? Typically, we have these in for 6 weeks, so it's all over the place. I know Balachi and his group are doing it for up to 2 months, which can sometimes be long. We've shown that this isn't the greatest slide, but about after 3 to 4 weeks is pretty much when you're going to get your maximum coronal and sagittal correction. And then everything beyond that is usually for pulmonary nutritional optimization. Like we talked about earlier, I think the traction camp at Focus was a big success at our institution. We use nasogastric feeding tubes for folks. We've proven that we've been able to increase their weight significantly, but also their pre-album has gone up as well. So we have nutritional optimization from a weight standpoint, soft tissue coverage, but also internal protein stores. And then certainly for the kids, just like Terry showed, that have significant pulmonary compromise, we've shown that this can also increase their respiratory status beforehand. They see respiratory therapists on a regular basis and has been shown to improve that as well. Just a couple of quick examples, and we'll go into the case. This is a 15-year-old who weighs 26 kilograms. She's in the first percentile for height and weight. She has a floating harbor syndrome, which is a rare neuromuscular disorder. She's ambulatory. One reason we show this is we get preoperative supine traction films, and basically what it has shown fairly reliably is that that's what you're going to get after about 5 to 6 weeks of traction. So that, again, you're not starting at 120, you're starting at 90, which is helpful. But also you can see she went from weighing 26 kilograms to 31 kilograms. We were able to take care of her in 1 day with posterior column osteotomies alone. This is another child we've shown what I think has even the most efficacy is in the early onset population and can be really flexible. So this is a kyphoscoliosis patient and someone who's only 90 centimeters and weighs 13 kilograms. So it's much too small for surgery, at least at the outset. But here they are after about 6 weeks of traction. We've gained 3 kilograms. They're now at least in the 2 percentile for their height and weight. But you can see now we have a dramatically improved curve. This is much, much easier to take care of. The traction did all the work. And we can put these magnetically controlled growing rods and significantly improve them with a single stage surgery. Now onto our case presentation. It's a 5-year-old male who showed up to us from Cyprus a number of years ago. He presented with progressive upper and lower extremity paresthesias, weakness, and ataxia. He had significant cervical kyphosis and came with a diagnosis of Larsen syndrome, which is sort of the opposite of arthrogryposis. They have hyperlax joints. They're often born with knee dislocations where their toes are touching their thighs. What's interesting, though, is he has significant kyphosis. He also has complete anterior posterior dissociation from C2 to T1. So he has basically no connection from the back to the front, no pedicles from C2 to T1. As you can see here, he has rather significant angular kyphosis in the center of his cervical spine. No significant motion, though, when he's bending on flexion extension views. It's a little bit more advanced imaging. You can see he does bend out a little bit when on the CT scanner, and in the MRI, you can see he has some cord signal change in that sort of little bullet-shaped vertebrae there at C5. So, and this is just a little bit of a 3D CAT scan, which I thought was kind of neat. It shows the vert's in the right position, but again, you don't have any pedicles, as you can see, which is unfortunate, connecting the back to the front, which presents a little bit of an additional dilemma. So our initial thoughts were what to do. Do you go all from the back and just decompress it because he is becoming myelopathic? All through the front, it's a rather deep hole to dig out, front, back, and do you hang him up beforehand?
Josh, can I ask you, we heard from Terry talk about how his traction, they got about 50% body weight. How's yours change for cervical traction in this kind of kid?
Yeah, much less and a much shorter duration. Typically, you only need to go, I think you go a little bit slower with adding it on, as we want to make sure they have good neurologic exams on a regular basis, every 4 hours or so while they're adding weight. But typically, you don't have to go above where it's more about 20 pounds, 25 pounds, but also it's based on the patient's weight. But you definitely get a lot more bang for your buck in the cervical spine as you would in the lumbosacral spine. So it's closer, and usually only for about 1 to 2 weeks as opposed to 6 weeks. So our first inclination was to hang them up.
Wait 1 second. Can I ask you how many pins are those? Is this an 8-pin halo? And
yeah, it depends on the child. Excellent question. We have these sort of torque wrenches that we use that begin at 1 inch-pounds and progress in 1 inch-pound increments. So we usually start with 2, and we want a goal for all the pins to add up to about 30 inch-pounds total. So if we can get up to 4 inch-pounds, times 6 pins, that's usually not close enough. So we want to do 8 pins for up to 4 inch-pounds. Typically for the teenagers, we'll do 6 pins. For younger kids, typically 8, 4 in the front, 4 in the back. If you have OI, we can have up to 10 or 12 pins to sort of dissipate the forces. So this is him. He actually tolerated increasing traction to 35 pounds, which was way more than we thought we would get. Sorry, 15 pounds of traction. He weighs 35 pounds, so almost half his body weight. But we have rather significant improvement here, which really helped us out. So we're no longer starting on the 1 yard line, but maybe now we're on the 30, 40 yard line. We've got a good head start. And I was always trained, if the problem's in the front, go in the front, problems in the back, go in the back. So for this child, we went in the front. We did a 3-level corpectomy. And again, because he didn't have any connection from the back to the front, we also did an ACDF uninstrumented at C23, and then put up ACDF as well at C7T1. We spanned all this with a single plate. That's all that would fit. His bones were pretty small. So we put him in a halo perioperatively. And obviously, this isn't something we want to hang our hat on. We want to come back for a second stage, but at least he was decompressed. So he hung out in a halo for a few days until he recovered. Then we brought him back to the operating room the following day, a few days later, and did a gill laminectomy, really just so we could pull off the C2 lamina and get a good view of the stump of the C2 pedicle so we could put a strong C2 pedicle screw in. These lateral mass screws in the middle aren't really functioning at all. They're just sort of there, so it's not a long rod, but again, the front isn't connected to the back. And then our next pedicle that actually connected to the vertebrae was down at T2. So we basically have a C2 to T2 construct in the back and decompression through the front. So the child actually did pretty well.
Did I interrupt to ask, can you walk us through how your decision making in terms of the levels and why you chose C2, T2, and how does that change based on your traction x-rays pre or post?
Yeah, we were hoping to only have to take out 1, maybe 2 vertebrae, but once we started doing that in the operating room, we just couldn't get anything level. So that's why we had to keep going down and take out C6. We were hoping just to take out 5, and as soon as we took out, but we also have to, it was a deep hole, so we kind of had to go from normal to abnormal and really find the dura and work centrally towards the middle. So we're sort of forced to take out 4 and 6. But then again, the reason we went up to 2 and down to 2 was because we just didn't have any anterior posterior connection. So that's why, again, just to get some anterior column support, we did a little plug at 2-3 and similarly at 7-1. And so that was the extent of the construct, just to go from a stable to stable construct. So that was the cervical part. Did well from that, actually 6 months post-op. We'll wrap this one up because I want to make sure we get to everybody. But this was fun. As you can see on the left image, he also has significant scoliosis below. So he actually did quite well. This just talks about cervical kyphosis and Larsen syndrome. If you ever see this, it's a significant problem for these patients. They need to get a screening cervical radiograph because a lot of them present with kyphosis and myelopathy. And then he also presented with this. So we also had another problem. We have about a 100-degree curve below to deal with. The patient was understandably shell-shocked, didn't want to come back for surgery that quickly. So we waited, and he's 7 years old. And now his curve's even bigger. So we actually went back. Now is what do we do at this point? He's 7 years old. He's too young for a fusion. And so we had a bit of a dilemma here with this cervical fusion and a significant thoracolumbar curve. We got a CAT scan to make sure everything was fused. just because we're not sure what to do in the pediatric world, we hang him up in traction. And so we did it again. And we went back for about 4 weeks of traction. He was able to get some correction, not a lot, not as much as we want. He was fairly stiff, unfortunately. And then we put a unilateral groin rod in just because we really didn't want to touch the cervical spine. We were worried about coming back to it. This is the first and last time I'll ever put a one-sided groin rod in. It's a lot of stress on that side, but it's just sort of helped us kick the can down the road a little bit, if you will. But unfortunately, not very successfully. So as you know, nothing kills confidence like follow-up. And after about 1.5 years of trying to do this, the screws and rods understandably broke because they're under a lot of stress. But now he's about 10 years of age. He's getting closer to having a reasonable pulmonary height and thoracic height. And now we can kind of convert him to a regular posterior spinal fusion. So we were able to take this all out. No preoperative halo gravity traction, but he was at least extended enough in the magnetically controlled growing rod where we could just do multiple posterior column osteotomies. And we just connected him top to bottom and we're able to get him in a reasonable alignment without halo traction. This is him now. He was 5. Now he comes back. He's about 10 years out. So he's holding strong so far. We're just sort of waiting for that upper cervical spine to see if there's any issues at the occipital cervical joint, because there certainly is a lot of stress up there. But knock on wood, so far we haven't seen that. So thank you.
Amazing. This is Jens. Can I ask a question? So first of all, congratulations. Yet again, a dramatic case and just amazingly well handled. And I love the trajectory of time. So quick question, cervical myelopathy. I mean, this is clearly a very compromised cord. How did you handle this intraoperatively during that anterior part, especially in terms of neuromonitoring? Is this something where you have reliable signals that you can go for? Do you go for a radiographic gusto? How does that actually play out in real life as you're trying to unravel that anterior cord from some whatever cartilaginous unloged vertebra?
Yeah, it was certainly challenging. That's why we toyed with the idea of going in the back first and just unroofing it to give us some more room in case we pushed back posteriorly with the anterior approach. But almost in a good way, he had anterior posterior dissociation, so there's a little bit of movement, we think, in the back. So again, we had hoped to just take out C5, but it was just too deep of a hole to dig. So that's why we ended up taking out 4 and 6 first and establishing where the dura was and able to kind of slowly attack towards the apex. But we were lucky he was ambulatory, although myelopathic. We just sort of thinned everything down. So we just had a very thin piece of bone back there, and then we were able to pluck it off without too much. But certainly is also a case of better lucky than good. We definitely got away with this one. He did well, thankfully. But again, just going from a known to unknown helped us out. And I certainly think not having that posterior column attached maybe gave us a little bit more wiggle room when going through the front. So we didn't overcompress him with the decompression.
This is a beautiful result, Josh. Can I ask you, do you feel like the Larson and the flexibility of that helped in any way in this case?
I thought it would. I think for the cervical spine it did. I was underwhelmed by what had happened to the thoracolumbar spine. It was a lot stiffer than I thought, which was unfortunate. So the second round of halo really didn't do anything. We just basically, meandered our way down the road until he was old enough to do a fusion. So in this case, cervical spine, yes. Thoracolumbar spine, unfortunately not. But again, just picking it apart with the posterior column osteotomies and taking your time, you can, with heavy implant densities, we're able to get a reasonable result.
And then Terry, I might ask you first and have Amr comment after. How do you talk about flexibility of the spine? How do you approach increasing that flexibility, and where does Halo fit in that algorithm for you?
I think that, particularly large curves greater than about 90 degrees in an AIS type patient or a neuromuscular patient, where I think for me is the sweet spot for halo gravity traction. I do think that early onset kids with curves above like 75 degrees actually do really well with traction. You can correct them quite a lot. I think that, halo gravity traction has been a great tool, and we use it a lot at the Shrine. And it's definitely made some cases that may have been really big long shots or may have required a 3-column osteotomy more amenable to an all posterior based instrumentation and procedure.
And Amr, what's your take on that, or how do you?
Yeah, so I think when we think about traction or no traction, the first thing is there's obviously multiple factors, and I know Terry's getting to this as well. It's obviously the radiographic parameters, but perhaps more importantly, it's what the patient looks like, right? What their pulmonary function is and what nutrition is. Because even if you've got a kid who's got poor nutrition, not good pulmonary function, they're not going to do well with surgery. They're likely to have more likely to have a neuromonitoring change. So a stiffer curve, skinny kid, bad lungs, they're getting traction regardless. Now, if there's a stiff curve, and again, magnitude is one thing, but as you know, if it bends out, it's going to bend out. It's more the rigidity. If it's not bending out less than 70 degrees, 80 degrees, whatever the parameters may be, we could consider preoperative traction. But many patients, when you lay them down, they're under anesthesia, and you go through, first and foremost, I'd say what I've learned in my career is make sure you position them appropriately. Positioning, especially in those really lordotic kids, if you bring that bolster down, especially for the rods, you can save yourself a lot of work because you're actually correcting the spine as is. And to Josh's case, when you get that cervical kyphosis, we actually had a series of Larson's kids who had cervical kyphosis. They get so lordotic. I mean, that was a sagittal plane deformity, really. That's what added the rigidity to it. That if through positioning, and then of course working through your facetectomy, osteotomies, your facetectomies, your pontes, and then what we like to do is to go ahead and go to the ribs, because the rib cage can really limit your correction. And then of course posterior discectomies, which we've written a couple of papers on, I think can help. If all of that doesn't work, then obviously doing something more aggressive. I do think if you're going to take a vertebrae out, you've got to get that concave pedicle. For a while, we were thinking of doing asymmetric PSOs, but in my experience, the risk of a neuromonitoring change gets much higher. You got to just blow the whole thing out and then correct them.
Great advice. And I think to your point too, there definitely are cases that are hyperlordotic, that even positioning the patient rotated, I feel helps me get access to that concave pedicle. Otherwise, I can't rotate the bed enough without them rolling off. And so that's the positioning, I think, is critical, like you said. So you would think that we only do halogravity traction so far, but you're trying to do all kinds of stuff. But I'm going to show, I think I'm up next. So I'm going to show a case that we did try traction, maybe it didn't work so well. So I'm talking a little bit about intraspinal anomaly. So this is a case of an 11-year-old girl, basically came into us through our international program from India. But she reportedly started about 7 months of age, had a split cord malformation. It was reportedly repaired. There was a report of a fatty phylum that was treated as well. And then another surgery a couple months later for a CSF leak. But then she reportedly was normally functional. She walked around, played, was doing well. About a year and a half, about 9.5 years of age, she started developing weakness in her right leg. So she saw primary care, saw some local doctors, and they didn't feel they could help manage her. And here's a sagittal view of the MRI, just showing the cord. Obviously, congenital kyphosis, where a vertebrae are fused together. The blue arrow showing that. In the cross section, that apex, there's actually, the cord is a little gray component, it's compressed, and there's a little bit of tissue on either side of it. And I'll show you a CT scan. There's a little bit unusual that may be related to the spinal dysrhythism. And so this is the kind of a coronal view as you go through it. Oops, sorry, skipped ahead by accident. Coronal view. And you can kind of see below the apex is a little bit of probably was a split cord malformation. It didn't look like it was, it looked like one dural sac, so it didn't look like two components, and then it reconstituted distally. The cord that was compressed ventrally from the kyphosis. And this is a CT scan showing it. So these 3 vertebrae and a little bit of the anterior portion, the one above, was fused as well. So we call them 3, 2, and 1. And then there's a little lip of bone. It's hard to see here, but the lip of bone ran down either side, basically around the cord a little bit, compressing the cord ventrally. It didn't seem attached to anything. There was no component like involved in the soft tissue. It was just very unusual, and I hadn't seen something like that before. So it took us a little while. So part of the question is, with congenital abnormalities, how often do we see intraspinal anomalies like this child might have had? And it's actually very commonly reported. So in literature, everything from multiple series, anywhere around 18 to 30, 40% of the time with congenital scoliosis will have some intraspinal anomaly. Some of the Chinese series have a higher incidence of split cord malformation, which we haven't seen as much in North America, but it is fairly common. So we routinely look at MRI in these patients pre-op. She obviously came in with this prior history, which helps us clarify it as well. This might, oops, I think there's a video here just to show a little bit the sagittal plane, just how they fuse together. The axial plane that I want to show here, you can kind of see, hopefully it plays through it, just a little piece of bone that was going down on the other side. Oh, and that kind of ran poorly. Anyways, trust me, there's a little bit of bone that went down each side. So this was the MRI. And I have a couple of videos to quickly run through. I'll run through the axial just so you can follow the cord. The cord is squished ventrally, and distally. And this is the sagittal view as well. And you can see there's no CSF ventral to that. This is just slightly squished. So, you know, she takes a little while, unfortunately, through the international program to get the kids to us. So she took about 6 months or a year to get here. And unfortunately, upon arrival, her right leg had no movement. She was wheelchair bound at the time. And her left iliopsoas was about 3 out of 5, quad was 4 out of 5, and EHL was about a 4 out of 5. Sorry, she was emptying her bladder, so thankfully. You can see the CT show you a little bit. There's a little bit of, I don't know if this is a reaction to her prior surgery or some residual from the dysraphism, but there's a little bit of bone on each side extending down over the soft tissue and pushing the cord ventral. So we tried traction in her. So we've heard a lot about traction so far. Partially, I use it a little bit as a default sometimes because these kids come in with different x-rays and they don't know what to expect. And it gives me a little time to plan them while they're in traction. Obviously, the bones are fused ventrally. I didn't expect those segments to pull out, but I was hoping that maybe a little above and below might stretch out a little bit and kind of realign her. And so with a little bit of traction, she had progressive foot weakness and about 10 pounds of traction. So it wasn't a whole lot for her. Sorry. So I asked me, Terry, or any of the panelists, how would you approach this? Or what would you do typically? Or have you encountered something similar? You change your plan?
You know, I'm going to show a similar case, as you know, Steve, with changes with traction. It is rare, but it certainly can happen. Usually the cranial nerves will act up first, as you know. But I've had a couple of kids where this has happened. And one kid, we actually had to abort traction altogether. The other child, the one I'll present, we were able to resume it at a lower weight and just go a little slower.
So, Amr, how do you decide whether to go ahead or abort? What's your
So you know, it really depends on the underlying what the pathology is. Here you've got a rigid deformity across the apex. I think, you know, putting him in traction may buy you some time. I think at this point, that needs to be decompressed. So for me, when it's rigid like this, I don't think there's much more value to continue with traction. Whereas if it doesn't have that rigidity, there may be some utility.
And I struggled with knowing whether this was from the dysraphism, could be tethered a little bit, contributing, or is it kyphosis? Obviously, it's compressing the ventral cord, and were they both contributing, or was one more than the other? But we agree. At this point, we agreed with your assessment and thought that traction was not beneficial. Obviously, we weren't going to pull out the apex, which was the problem was. So we decided to take her for surgery, just move to surgery to get sooner. So just as an option, as a discussion point, there is a relatively, I'd say relatively new, it's in 2005, 20 years, I guess, but approach that Dr. Koban talked about, which is basically shortening osteotomy to address tethered cord. So for patients that have tethered cord or potentially recurrent tethered cord, you can kind of decrease the distance from A to B to try to relieve the tension on the cord. And this is what Dr. Koban described initially, kind of partial VCR, taking the disc out above, basically shortening 12 to 14 millimeters to take that tension off craniocaudally. There've been about a dozen or so case series out there with good results with it. So we thought that was something similar in this case. We thought by shortening her and doing a partial VCR, we would decrease the tension on the cord and relieve the ventral tension as well to maybe address both, maybe kind of two birds with one stone. So that's what we did. We did L1-2 VCR on this patient with a small cage and just a T10 to S1. Probably could have gone to the pelvis, to be honest. Fusion. Harry, let me ask you, would you have gone to the pelvis in this kid? Do you think that's safer? Should we have?
Yeah, I mean, typically, I think we have longer constructs. We do end up going to the pelvis. I know sometimes it can be a challenge in these hyperlordotic patients to access that and connect the rod. So I think it's always good to have the long screws that go in front of your axis of rotation when you can. Not always the case. But yeah, I know sometimes it can be a challenge in these hyperlordotic patients to just access that channel. But typically, yes.
May regret it later, but I think we left it just to try to give her a little bit of motion across the side joint if she needed it. But we did manage. The primary goal in this case we thought was to address the neurologic decline if we can, at least stabilize it, prevent her from getting worse, hope for improvement, and then secondarily stabilize progression, the curve, kyphosis, and prevent that from getting worse as well. So that was her end result, and then she went to the patient rehab side, and thankfully she actually improved. So this is her about 6 months later. So this she's back in India. So obviously has a little bit of gait abnormality, but she was walking, which was an improvement. So far so good. We'll see how she does over the next couple of years. We'll stop there. Then we'll let Amr, you can pull up yours, Amr, if there's any questions, we can take a look. Otherwise, we could go ahead.
Can I have one question?
Oh, please, yes.
So bladder function. So how was that? I thought I saw something about bladder function. This is obviously kind of conus things. So how did that get assessed, and how does that weigh into your management? I like the shortening a lot. I've not done one, but I know Nick Theodore has kind of almost pioneered that, and in the adult world, this is certainly gaining a lot more traction.
That's great. Yeah, I think in her case, she actually we just did routine bladder scans post-void, and she was fine. She had no post-void residual. But we do, if we have time, we'll get urodynamics on children as well, and actually get formal testing. So actually test the bladder, the sphincter tone, and everything, and get a formal report from the urologist, and it helps us sometimes distinguish from a neurogenic bladder. It's in the tethered cord literature. Unfortunately, it's the least likely to improve once you have loss of bowel bladder. It's somewhere around the 30–40% chance of improvement once you detether them, unfortunately. And in young infants, it can be hard to track if they're less than 3 or so. You don't have an objective metric to watch, but we'll try to get it when we can in kids. Great. And then next we have Amr Samdani. Needs no introduction.
Well, first of all, just a big kudos to Steve. Congratulations on putting this together. And I mean, that girl that you just showed, I can tell you there's several others that he's helped in a very, very similar manner, and great presentations, everybody. So listen, my charge is just to talk a little bit from the neuromonitoring side. I'm going to show 3 cases that I've learned from over the years, one that was more recent, and just share some of my experiences. So here are my disclosures. So we're going to start out with this girl. It's interesting. I mean, these curves that are 120 degrees, we see patients from all over the world, and there's two types of patients that we see that have severe curvatures. There's the patient that has neglected care. They just don't have access. They come from a region where there isn't access. And then there's another set that are trying to avoid surgery. And this child, who's actually in medical school now, fell into that category. Wonderful parents, but just kept going down the non-operative route with conservative management. So we take her to the operating room, and this was our plan. We were doing a T4 to L4, and sure enough, putting the concave pedicle screw in, our neuromonitoring team says we have a change. And the first point I just want to make is that there is variability as to what is considered a significant change. For us, if the motors go down 50%, that's our institutional policy, that is considered significant for us. There's other institutions where they would say it's an all or none phenomena. Some say greater than 80%. There's only one society that I'm aware of that's actually standardized what's considered a significant event, and that's the Japanese Neurosurgical Society, that says greater than a 70% drop in transcranial motors. This child had a greater than 80% drop, and trying to plan out, what we're going to do. Obviously, we go through the checklist that Mike Vitale has popularized, and even today, one key element on that checklist is to consider calling a colleague, because obviously you're in the middle of things. It can be stressful, and getting a clear head to talk you through it is never, ever a bad idea. And the point I like to make here is you've seen a lot of slides that show screws running up and down the spine. It is perfectly okay to skip screws. And basically at this point, when I see this, I start going back to what's our overall goals of surgery: getting correction, balanced spine, preventing a complication. And at this point, we end up changing our plan, because what we want to do is we want to make sure that we're able to finish the case, especially because this child actually had a second loss of motor evoked potential. And I just want to show you our last exercise. Yes, doesn't have screws running up and down the spine. We skipped those concave pedicles. We went to the easier convex ones. And I promise you that she does not miss those screws at all. So one learning point that we try to, teach our fellows and our colleagues is perfectly okay to skip. Just think big picture. Another really important concept we all know from Vitali's neuromonitoring checklist that raising the blood pressure is one of the early steps when we're dealing with a change intraoperatively. This is one of the few papers that Dave Skaggs has actually published that shows that 20% of the time there's actually going to be a return just from raising the blood pressure. And the time to return, again, another important element for us to recognize, is about 16 minutes or so in those patients that have an improvement of their transcranial motors just from raising blood pressure. But there are some patients that may even take longer, 37 minutes at least in his cohort. I want to go ahead and share this patient that I had several years ago, 13 years old, had a congenital muscular dystrophy, some sleep apnea. We take her to the operating room, we're cruising along, and we're near the top of our construct, I believe we're on T2, and there's a complete drop. You can see it at 12:35. So we do the checklist, we check blood pressure, hemoglobin. We end up reversing our last few moves. We take the left T2 screw, the right T3 pedicle screws out, and there's still no change. So what do you do at this point? Obviously, you can continue taking screws out, but if you have access to 3D imaging, axial imaging, you can bring in the O-arm. And sure enough, we brought the O-arm in, and this is what we saw. 2 screws at T6 that probably by themselves may not have been significant, but because they were placed at the same level, clearly they were significant, because as we take the screws out, literally within minutes, the signals come back, and we're able to finish the surgery. Lastly, I just want to finish off with this third patient we had at our hospital, severe rigid kyphoscoliosis, obviously a type 3 spinal cord, which most of these patients with these severe deformities are going to have. To Hen's point earlier, we maximized her nutrition, placed an NG tube in. We're trying to get her up to goal weight. But as Steve had asked a little earlier, sure enough, as she's going up from 12 to 15 pounds, she starts losing, she gets numbness, she gets tingling. We take the weights off, and then we restart them. And then she had a fairly complex hospital course where her halo acted up. But the point being that you can see this. And if you do see this, if you want to continue with traction like we did in her, she had a fairly severe curvature, you have to go back and probably go a little slower. And that's what we ended up doing. And then she did not have issues progressively, but it did point to us that she has a very sick spinal cord. And our surgical plan was, anytime you have a very sick spinal cord, we changed it around a little bit. There's more talk, not literature yet, coming up being very aggressive and taking out concave pedicles. So in her, with her sick spinal cord, with motors, that her signals weren't coming in great, although they were obtainable. We used our pre-op signals. We placed a stabilizing rod on the convexity and went after the 3 apical pedicles first to really decompress it, then continued with the VCR with the goal of, obviously, we're always trying to maximize correction, but we want to try to get correction and get her off the table. And here she is. She did get taller, but obviously still has some deformity. These high-risk patients, Raj Iyer and a consensus group of expert surgeons put together some guidelines. And I do think that there's some really worthwhile information. I'm not going to go into the details of this. They really came up with what determines what's high risk and then what are some preventive strategies. And here's a list there. You don't need to, you can't see all the different categories that we have, but some key intraoperative actions which helped us were the pre-op signals. I think making sure you have a short convex rod. Many times during 3-column resections, when there are changes, just some compression across the convexity can improve signals. Making sure you really have a circumferential decompression, and perhaps most importantly, it is perfectly okay to separate these more complex procedures across 2 days when it's not feasible to get them done in 1 day. So I'm going to go ahead and stop there.
Great cases, Amr, and great lessons. Thank you very much. Can I ask you, the last case you showed, obviously combined both halo gravity traction and a VCR. or at least a multiple pediculectomy, how do you decide when you need something like that, a PSO or VCR on top of halogravity retraction?
Yeah, so there's a couple of different factors. Number one, if there's a myelopathy, neurological, that's a given. Number two, if there's been surgery before and there's just a short, rigid apex, without a doubt, you're going to go ahead and need surgery. And what we found is we did a study through the Fox study group that in really rigid curvatures that are large, you are less likely to actually have a neuromonitoring change if you go ahead and take that concave pedicle. So sometimes what appears to be the more complex procedure is the safer procedure. So I'd say rigid deformity, any myelopathy, but if there's a more of a sweeping curvature where you don't need focal correction, it's much better to get that throughout the curvature.
Thank you, Amar. I might ask one of the questions. I might direct this to Terry. We had this question from one of the attendees, is saying, in some of these cases, how is pulmonary function? So in the severe cases with impaired pulmonary function, and is there a contraindication for surgery when it's too bad? Is there an upper limit to when that you just say you can't do the surgery? And how does traction influence that?
I think that it's a kind of a group decision for these patients. Some of the patients who have severe pulmonary compromise and those ones who are really worried about them surviving the procedure, we'll get together as a group, the four of us, and then also talk to our anesthesiologist and the intensivist, and really try to figure out whether or not it's worth it to go ahead with the procedure. But I don't think that there's a set number or in terms of PFTs that we'll kind of look at. We'll look at the patient on the whole, look at their cardiopulmonary reserve, and then really try to figure out what we can offer. And if it turns out that the risk is too high, then it's better for the patient, then we will say no. So this is kind of looking at the patient on a whole and all of us getting together to really discuss it.
And then Josh, can I ask, Amar showed some cases where there was a neuro change or two. How do you approach, I think, how many times can that happen before you would stop or do you pause it, and what factors influence that decision?
Usually you get, one get out of jail free card, we'll say, and then you can undo your last move or two and things come back. And Amar published a great paper a few years ago, which I think has really helped out a number of us, that if you have a signal change and it comes back, that doesn't mean you have to bail or necessarily really shortchange the patient on their correction. If you can figure out what caused it and fix it, undo it, raise their blood pressure, if it was a screw or something, take that out, then oftentimes you can actually get very reasonable correction afterwards. I think if you get a second hit, that's when you really have to decide where you are and can you proceed or not. And it also depends on when. I think if you haven't done a 3-column osteotomy, you haven't destabilized the spine yet, and you have a second change, then I think it's a good idea probably to close up shop, come back later, because that second hit is likely going to have a longer recovery period. And then, you may not, if you go any further than that, you may not get it back. So, but sometimes if it is during the middle of a 3-column resection, you have to just keep going and you have to figure out where you are and what's causing it. And often it's just compression at the ends, or some point, maybe you need to shorten the cord a little bit, but just figuring out why will help dictate it. But usually you get one get out of jail free card.
Great, thank you. Maybe a final question for Amar. So if people are starting to do these complex cases, VCRs, any words of wisdom or a little piece of advice when you start?
Yeah, I think the key things, obviously, on top of doing the normal things that we would do, cadaveric stuff, I think visiting a surgeon is a really important piece. I know I've had been lucky enough to visit a couple of surgeons. I've learned a ton. I would say pulling in one of your partners who's experienced, who can take you through those is certainly a very, very viable option. And depending on your institutional support, that's something I would really recommend. I would say just doing a 3D model, having a model of the spine deformity is critical. I mean, really understanding it, having it printed out, having that with you in the operating room. And then I would tell you, again, perfectly okay to stage it. I mean, if you're at a point where the signals are back, or you've got a lot of screws to put in or a lot of work to do, take hardware out, perfectly okay to go ahead and stage those procedures.
Great. Thank you, Amar. Great words of wisdom. All those
Hey,
great hits that paid off.
Can I ask you a question? So these are amazing cases. I'm just in awe of what you've done there. The big topic now, and Dr. Samdani and I were just at a meeting where we talked about robotics and image guidance, and there's a new generation of surgeons who is born with navigation. Can you share with us how you've put these screws in so masterfully and so safely? Usually, is this still all good teaching and clean technique, or is this done with the magic of image guidance? I know there's no robots. We talked about that earlier.
So I can just kick it off. I would just say I can tell you that these three guys are truly some of the best anatomic pedicle screw placement guys that I know of that I've worked around. That being said, we have a low threshold for bringing navigation in, but our main approach is we really just do it to check the screws. What we find though with navigation is when you need it the most, and at least right now, when you need it the most, the really tight pedicle is when it's the hardest to get it to work properly. So that's why I think we've been relying more on feel and anatomy, but there are times when we will pull it in as a backup without a doubt. And these three guys are, I'm telling you, I see their x-rays and the screws that they put in. I know these guys had 2 big cases today, and they truly are masterful.
I will say when he first got it, Josh and I were like a little more disdainful. Amr was like, "Oh, we should get it," and we're like, "Oh, we don't need it." But it actually is very helpful. We do use it. I used it today early. We had a low threshold to bring it in. It doesn't always work great. We find for tiny sclerotic, like almost non-visible pedicle, but will still help us guide the entry point, and then we can use kind of technique and palpation to try to get it out in. But it is, I think, very helpful. And I think it'll just continue to improve as we go. So the technology as improves will help improve our outcomes, obviously.
I think it's
That's
beneficial
impressive.
to help you out when you're lost or in a congenital case or revision where the posterior anatomy is a little bit uncertain, to really just help guide you where your starting hole is, and after that, you can go by feel.
Yeah,
No, I
Dr.
use it.
Skaggs, sorry, Dr. Skaggs is in our lab a couple of times at SSF, and he's taught us how to use a drill to take this down the pedicle. Is this something that that you use? Is this an oscillating thing? And to make a pre-op map, kind of where you have no-go zones where the pedicle is just too dysplastic or the cord is too draped over the pedicle?
We definitely will do that at times. I think in some cases, a concave pedicle that's just very non-existent, almost a type D, like Linky talks about. And sometimes we'll just skip it. And I have a low threshold to skip it or put a band or substitute with a different fixation point. I will use the drill, the slow speed drill, just to try to get through a sclerotic pedicle. So if it can't feel the actual marrow, I'll use the drill to try to create a hole. It's a little different from what Dave does, but a similar overall technique.
I think we're at time. Rick, do you want to make a closing comment? I mean, I was in awe. I learned so much, and I really enjoyed your wisdoms, and the transference to adults is clear there. One quick question. How long do these halopelvic tractions last? I know you're in a unique healthcare system, but what's the time frame? What gestalt are we talking about?
Typically about 6 weeks is on average. By then, after anything longer than that, usually the pins are starting to get a little red. So typically about 6 weeks. Again, some of that time's for the curve correction, and a lot of it is to optimize the patient from a pulmonary and nutritional standpoint as well.
Good, no, impressive. Rick, Dr. Guy was my teacher, so Rick, give us the words of
Well,
wisdom.
listen, I particularly enjoyed this because when I was a resident at Penn, we had a lecture by Howard Steele, and at that time, all they had was Harrington rods, and he said, well, you measure the Cobb angles, and then you end up fusing everybody from T4 to L4, and we all sort of chuckled. But it's really come a long way. And at Children's, we used to see a lot of these, unfortunate kids. But the amazing things that you do today is just incredible, and the unbelievable cases, and the really good things you do for these unfortunate kids and make their lives happier. And the amazing thing is, despite their disability, they are such happy kids. So this brought back lots of memories, and hopefully was very instructive for everybody out here. So I congratulate you, and I'm glad that you're part of our team now. So we look forward to having you present again. Thank you very much.
Thanks for having us.
Thank you.
Thank you very much.
Thanks, everybody. Thank you so much.
Bye.
And Corey, you're going to put up the, okay. Don't forget to claim your credits, 1267. Thanks, everybody.
Thank you.